Thank you. Everyone introduced himself, so I should do it in the same way. My name is Martin Bortlik, and I am a gastroenterologist interested mainly in IBD, and currently I serve as a head of the Czech IBD working group, and I'm very happy to have the chance to tell you a few words about IBD in the Czech Republic. IBD in Czech Republic is one of the main interests among our gastroenterologists, and our IBD working group was established more than 20 years ago and was founded by my colleague and head, Professor Milan Lukáš, and as I told you already, I'm honored to serve currently as the head of this group. Our aims are mainly education of Czech gastroenterologists, but not only Czech gastroenterologists. We closely cooperate also with the Czech Patients Organization. We prepare guidelines for our physicians, and we try to do also multicentric clinical research. We are happy to cooperate also with European Crohn's and Colitis Organization, and also with several others group that aim to be interested in IBD worldwide. The Patients Organization you probably know already. You had a chance to see Martina Pfeifferová, who is the head of this organization, and several other members of the committee of this organization, which is more than 10 years old now and has more than 1,000 members. And we are happy to help this organization with achieving their goals and aims. What about the epidemiology of IBD in Czech Republic? You might be aware of this well-known study done by Johan Buriš from Copenhagen, Denmark, a couple of years ago. The study was organized by Epidemiological Committee of the European Crohn's and Colitis Organization and involved 25 countries throughout Europe and Israel. And the main goal was to find out what's the incidence of IBD in Europe, meaning how many newly diagnosed cases of IBD are in those countries per year. And I can tell you that the Czech Republic lies not only from geographical point of view in the center of the Europe, but also from the epidemiological point of view. The incidence of IBD is somewhere between the western and eastern part of Europe, because there is, as you might be aware, so-called east-west gradient, meaning that the incidence of IBD in Western Europe is almost twice as high as in eastern part of Europe. The current number of IBD patients in the Czech Republic is around 55,000, which is approximately 0.5% of the total population of the Czech Republic. And what is even more important is that the number of patients increases substantially, and over past 8 years the number of patients with ulcerative colitis increased for more than one half, and patients with Crohn's disease of almost 2/3. So we have now, as I said already, almost 55,000 patients with both diseases, half and half, ulcerative colitis and Crohn's disease. The working group for IBD of the Czech Society of Gastroenterology and Patients Organization work together on several projects. One of the most important is to provide patients, with appropriate and reliable information, and we prepared and just recently updated our brochure on biologic treatment, and as you might know, as you might see here, patients were used the very well known term, a very well-known title of the Woody Allen's movie on this brochure. You also know very well these patient guidelines that were prepared in collaboration between ECHO and FK, and that were also translated into Czech language. And another project we cooperate on is, or was, already published last year by my colleague Dana Ďuricová, and the aim of this project was to assess the quality of life in IBD patients in Czech Republic, and I'll let you know about few results of this study. First part dealt with the treatment satisfaction and adherence of patients to the medical treatment. We were quite surprised, but nicely surprised that most patients, 85%, were fully satisfied with their treatment and management of their disease. We also looked at the management in terms of number of daily dosing, which is an aspect which is very important in terms of adherence, or influences importantly the adherence of patients to medical treatment, because the number of daily dosing, if 2 or more, substantially decreases the adherence. We now try to give the medication to our patients once daily, which is current trend, and the occasional non-adherence, probably mainly due to the number of daily dosing, was approximately 1/3. The predictors of non-adherence, or good adherence, sorry, were higher age and patients who were interested or who are interested in IBD news adhere better to the treatment. We were also surprised that almost 1/4 of patients hide their IBD from the employer. 40% work with stress due to IBD and has some limitation in their work. We also looked at main symptoms, and as you may see here, the most frequently seen or reported symptom was not the abdominal symptoms, diarrhea or abdominal pain, but fatigue and weakness. So this is the experience of our patient, and this was something new for us as physicians. Another project we cooperate with patients' organization is aimed to look at or was to look at pregnancy and newborn outcomes, mainly in patients exposed to biologics during pregnancy. But then we just recently realized that we a little bit forgot our men. And therefore we try now to improve this, and we started a project that is aimed to look at male patients with IBD and their difficulties in sexual life. And last but not least, we are still more and more in contact with patients from abroad. And just recently, a couple of days ago, I received this email where a patient from Ireland asked me to help with her treatment while coming to Czech Republic. And fortunately, I can reassure her, because the availability of biologic therapy in Czech Republic is very nice, and since the very beginning time of the biologic era, since 1998, we had infliximab available here, and now throughout last 2 decades we have all the available biologics in our therapeutic armamentarium. The organization of biologic treatment in Czech Republic is done as a central system, so we have around 30 centers throughout the country where we can provide our patients with biologic treatment. So I think that every patient should not be worried about coming to Czech Republic, so come to Czech Republic and we'll take care of you. Thank you very much.
Thank you so much, Dr. Bortlik. Are there any questions or? Yes, Louisa have it. Is there anybody else?
Hi, and thank you for your presentation, and I'm very happy to meet you again. You remember a couple of years ago, no, 3 years ago, we met on the boat. I have a kind of comment and question that is also addressed to our member. I saw that you are tackling the issue of men's infertility, and I think it's something really interesting, in particular because, as you, I hope our member remember, we are now working on a strategy plan that is including one theme that is life cycle and well-being. We have 2 themes. So I think it would be really nice to share more information in the type of activities and if you are collecting data in which way, because I think it could be something that could be shared also to all our members. And since we think it's important to learn from each other and we don't have to reinvent the wheel, this is a theme that could be really interesting for many associations. So we would be pleased if we could share and work together on that.
I have to agree, of course, and we, as I explained, cooperate with the patients' organization on not only this project but on several others, and of course the results will be available to the whole community of IBD patients, will be present on the website of patients' organization, and we hope also that they will be published in some peer-reviewed journal, and the patients' organization will be a part of the authorship.
Okay, yes, Marco?
One very quick question on my side. You said that the number of patients that have been diagnosed over the last 10 years has increased with 55 to 65%. Do you think it's a result rather of better diagnosis, or it is really the occurrence of the disease that has increased substantially? Thank you.
I think that both probably is true, and that not only the diagnostic process improved and the awareness of the GI society increases over time, but also the real number of IBD patients increases, and it's probably the result of the change in the lifestyle, which is more similar to the Western lifestyle. And therefore we know that the changes that are driven by the lifestyle are much quicker, much faster than those that are based on genetic background, of course. So I think that this is the most important factor that influences this increase in the number of IBD patients in the country.
I have a question for you. You mentioned that the compliance is correlates with age and the interest in one of the research that was conducted. So it correlates with age and the interest in learning about IBD. How do you measure the interest to know about IBD? This is one question. Another question is maybe not directly related to what you presented here, but do you think that compliance can also be in some way correlated to the length of disease, so the time from diagnosis?
Yeah, thank you for the question, which is interesting. I think that this is the result of this study was consistent with results of several other studies published worldwide, and that the fact that patients who are more interested in news in IBD or informations about IBD are more prone to adhere to the treatment or to comply with recommendations from their physicians is logic. And in this particular trial, it was measured simply so that patients reported whether or not they are interested in news in IBD. As far as the second question, yeah, there are clear data indicating that the duration of disease influences the adherence or compliance. We now use, rather than compliance, term adherence, which is better for understanding the true aspect of that. And we know that patients with short duration of disease has worse adherence to as compared to those who has longer experience with their disease, had more relapses, and already got some experience with their non-adherence as well. And the non-adherence is a negative predictor for disease course. Patients who are non-adherent to treatment have more relapses, have more chances or a higher risk to be hospitalized, high risk of surgeries, higher risk of several other complications, including colorectal cancer. And we think that this experience from a very beginning part of the disease eventually leads to improvement in adherence. Unfortunately, many patients need to get this own experience to improve their adherence.
It's me. First of all, thank you for being here today for your speech. We really appreciate that. Talking about adherence, I saw that the adherence, the loss of adherence is around the average is 25%. I remember in Italy there was a study in which they found that 13% of patients were interrupting the treatment without telling the doctor. So my first question is if you have this kind of data in your country, and also if you have it, do you think this response is related to a bad communication between patient and doctors?
We have a data published more than 10 years ago in IBD journal, and they show that the non-adherence is somewhere between 40 and 50% in general, which is similar to many other medical areas where their patients are in need of long-term medication, because this is the problem. The problem is long-term medication during the remission when there are no symptoms, no complaints, and patients may believe that the same will be without the medication. So the non-adherence is somewhere between 40 and 50%, and I think that the communication is one of the most important factor that influences the adherence, and that it's a job for gastroenterologists to mention this aspect regularly, not only once at the beginning or once 5 years or so. We should stay. We should try to push the patients to adhere to the treatment every visit. And it should be done, of course, very gently. We have to ask patients whether or not there are problems with the medication, how they feel with the medication, and so on. And I think this is very important, and adherence is now one of the mostly studied aspects of long-term medication in general.
I would ask, do you practice stool transplantation, and what do you think about these effects?
It's a nice question, and one of the topics we are interested in currently, because there is a study in the Czech Republic, one of the very few prospective studies that are being done currently in IBD patients on stool transplantation. In fact, we try to collect patients with left-sided ulcerative colitis and compare the effectiveness of fecal transplantation with mesalazine enemas, which is not as easy as we thought initially, because of difficulties in cooperation with the GI community, not with the patients. Probably patients would be more prone or more willing to undergo this procedure. In general, there are not as reliable data regarding the effectiveness of fecal transplantation in IBD, especially in the UC, but they seems to indicate that it could be effective. There is a clear indication for fecal transplantation now, which is Clostridium difficile infection. There, we know that in this indication, fecal transplantation is the most effective treatment, especially in patients who have relapses of C. difficile infection. But in IBD, still we have not, I would say, enough data to accept this treatment as a standard management of UC. But it seems promising. It seems promising procedure.